four phases of clinical research. We have with us, first of all, I would like to thank all the participants and the experts who have joined uh, very early, because this time we are having a bit early timing for this journal club. So all of them are very busy, and they have managed to join. And first, I would like to express the thankfulness also. And we have Dr. Amkuti Sir, Emeritus Professor, SCT as the panel expert. Sir will be giving the expert analysis, and we have the coordinator of IAP Journal Club, Dr. Pathuravan Sir, the senior consultant from PRS Hospital, and Dr. Divakar Jose is, he's a regular, faculty from KIMS, as far as during the journal clubs and all. Welcome to Dr. Divakar Jose, Sir, Associate Consultant, Pediatric Critical Care, KIMS Health, Trivandrum. And also we have Dr. Femita, Senior Consultant and Academic Coordinator, Department of Neonatology, KIMS Health, Trivandrum. And I would also like to express my thanks to Dr. Neela Gupta, Madam, Senior Consultant, Academic Coordinator, and a good friend, colleague, mentor, teacher. Madam will be also joining us. And we have two enthusiastic postgraduates, Dr. Nikhil Raj TS, final year Dependent Resident, and Dr. Vidya VS, Dependent Resident Pediatrics, who will be analyzing both from himself. Now, this is an interesting topic in the sense nirsevimab, which is a monoclonal antibody. And we all were discussing a lot about bronchiolitis, a lot about its treatment protocols, what is useful in bronchiolitis, what is usually given. Now, it is an always a problem for the pediatrician as well as the parents when the baby gets respiratory, distress in a very early age of life, like 6 months or even before. And sometimes it may take a long time for recovery. And sometimes clinical evidence may show that none of these, like steroids or bronchodilators or whatever which is there, may not be actually, clinically has not been shown any evidence of any use or not. That is a point where a monoclonal antibody which can be given, which will prevent these RSV infections, comes into play. And it is very interesting to note that already many countries have been instrumental. They have already started even routinely giving monoclonal antibody, and including KIMS, there are hospitals which usually give this Remdesivir. And I'm looking at a time where the government of India will also be routinely sponsoring, giving this monoclonal antibodies to children from the neonatology, who are graduates of the neonatology department, or even routinely to our infants born and all. So at the outset, I would like to invite Dr. Srijit Kumar, Secretary IAP Thiruvananthapuram, to give his opening remarks. Dr. Srijit.
Okay. Thank you for inviting me, and also I'm very glad that we are continuing with the Journal Club, even though we have a busy schedule for the faculty as well delegates, as well as in the Zoom schedules. So we have preponed our program to 7 p.m. today, and we have another Zoom at 8 p.m. So I think we will move on to the academics as early as possible. Thank you.
Okay. Now today, this is the topic itself very interesting, because it is it's a trial. It is a randomized controlled phase 3B trial. So it will be very prudent to have a short topic discussion on the pipeline to patient, the four phases of clinical research. Now I would like to request Dr. Femita Madam, Dr. Divakar Jose to take the stage for the topic presentation, which will be followed by the presentation and analysis. Over to Dr. Femita.
Thank you very much, sir. Thank you, Srijit sir, and to Padmanabhan sir, and yeah. Dr. Anju had also requested to put in a few words about how practically we are using it as well. Maybe that one or two lines I will tell after we finish the first part about the phases of clinical studies. Can we share the slides, sir? Srijit sir, it's okay, no? We can start, Sir.
Yes, sure, we can start.
Sure. Yeah, you can start. We can start.
Divakar, yeah.
Nikhil, please share the slides.
Vidya. Just one or two words. Meanwhile, while they're looking at the technical part, Nirsevimab is one of the drugs which might be called as unprecedented till now in the type of immunization or vaccinations that we do, because we don't give passive immunization for any of the respiratory illnesses other than for respiratory syncytial virus. And it is a drug that has caused or done a lot of good in the Western hemisphere of the world. For them, RSV is more of a seasonal disease which occurs in late spring and then autumn and then winter. But for the countries which are closer to the equator, that is of course ours, there's no seasonality. So at all times, children are at risk of RSV infection, just like we see in routine clinical practice. And it is quite a devastating disease, especially if it happens to a child who has a bad lung underlying. Like we have seen bad RSVs requiring ventilation and prolonged hospitalization if they are preterm bronchopulmonary dysplasia, or if they are congenital heart disease, neuromuscular disorder babies, or if they have primary ciliary dyskinesias. With the advent of genetics, now we know also that they have an underlying problem. So it is a very relevant thing, and it is unprecedented that we don't use passive immunization otherwise. So I like it that you all had thought of the phases of clinical trial being introduced in this kind of topic, because that's how the drug comes into the market. So I will just take 2 minutes only. You will see that it starts from 0 and goes all the way to 4. Simple is that if it starts with a number, that is, if it's 1, 2, 3, and 4, then it means that it is on humans. So part of it will be on human volunteers, and the other will be on people who are actually patients or who have the disease or who have the risk of disease. The 0 is preclinical, that is either in the lab setting or in the animal models. So 0 we won't talk about just now. 1 is usually on healthy volunteers, and the purpose is mainly to find out if the drug is safe or not, and also to start their work on dosing, that is to start on mini dosing and to see what doses can actually be given safely in human beings. So these are on healthy volunteers usually, and they are in very limited number of patients, or not patients, on human beings, and it is a very short also, the phase 1 trials. So this is a starting point of clinical or human research. Now phase 2, the rule is that only if a drug passes a phase, then it moves on to the next phase. So if it doesn't pass the safety phase of 1, then it doesn't move to phase 2 at all. So once they find that in healthy volunteers, it's okay in a small number of people, then they move to phase 2. Phase 2 can be actually in volunteers, or it can be in some people who are already patients. But the focus again here is safety rather than efficacy. So here, even if they're just normal people also, we're trying to find if the given doses which they found from phase 1 are safe or not. So the primary thing is, one is for dosing and for safety. Second one is for safety mostly. Phase 3 onwards, it is more of efficacy. So efficacy means that you have to either have the disease or you have to have a risk of disease. So that also is in a small number of people. It's a short thing, like it may be 1 year, 2 years, and it is focusing on both efficacy as well as on safety. Now, phase 4 is a much larger thing that requires a lot of ethical clearance, because you're working on patients, you're working on a large number of patients. It's usually multicentric, but the pinch of salt that you must take is that many of the phase 3 trials are sponsored by pharmaceutical companies. So you might have to look at the disclosures that the study participants or the study principal investigators have given, whether they have taken money, whether it was sponsored or not. So the results might have to be taken with that pinch of salt or without that pinch of salt, depending on whether there's any conflict of interest. So phase 3 is mainly for efficacy and safety. So it reverts from safety to efficacy and safety with priority that way, as you move from 1 to 2 to 3 to 4. And 4 is after the drug is approved. That is, if it is US, it's FDA. For us, it is a Drug Controller General of India, or if it is FSSAI, if it is like a food product. So it has to be already approved for public use if it has to move from phase 3 to phase 4. So phase 4 is a post-approval phase, a post-marketing phase where it is already gone into the market. So thousands of people might receive it, but the safety monitoring committee and the efficacy committee will be looking at systematic data to find out if the drug is efficacious as well as safe. So in post-marketing surveys, you might find multiple centers taking part. And for long-term effects of some drugs, like we know that Nirsevimab we started using only last year here, that is in India, that is late of 2025. So we might have to have in our population and our genetics, how is it going to affect human health for a long time to come, whether it is good effect or bad effect. So that's how you move from phase 0 to phase 4. I'll stop with that for the phases of clinical trials. Divakar, you want to take over?
Thank you, ma'am. As ma'am has said, this study is mainly about prevention of RSV, which we all know is a major disease affecting young infants. The next slide. So currently we have few options like palivizumab is being used in was being used at high risk children, and a maternal RSV vaccine is also being tried, and the nirsevimab is the latest one in the currently studied preventive strategies. So next slide. So it's a long-acting monoclonal antibody with a suggested to have a single intramuscular dose for a seasonal protection, while nirsevimab is supposed to be given monthly. So next slide. So we today's study is actually follow data from the real harmony study. The actual initial harmony study was the phase 3 trial. The data was published in NEGM in 2023. So they gave nirsevimab for healthy infants and one group, and in another group they did not receive any prophylaxis, and they gave the drug just before the RSV season, and they followed up till the end of RSV season. So so some of the children received it for the effects were studied for 1 month. Some of the children the effects were studied till 5 months, and the median observation period was around 2.8, which was their projected studies, 2.8 months, which was the older studies duration. And in that duration, with that outcome, it showed a good improvement, which was accepted by the many Western societies, and it is being suggested into the protocols. So now they have followed up its effect for some time, and they have observed the effects for at least 180 days, and they have brought up the follow-up data of that trial, and they have published it separately to add the more support for the nirsevimab. So today's journal club, Dr. Nikhil will be now presenting the details of the that follow-up data and how it turned around. Over on to Nikhil.
Good evening, Manandon. Today I'm going to discuss the journal 180-day efficacy of nirsevimab against hospitalization for RSV, lower respiratory tract infection in infant. The study got the name Harmony, a randomized controlled phase 3B trial, which is published in the journal The Lancet Child and Adolescent Health, July 8, 2025. So as why there is a follow-up study, because early results showed protection up to around 150 days with a median of 2.3 months. So need to evaluate the protection for longer duration, assess the real-world effectiveness and safety, which will support the policy decision for immunization. So the study objective, the primary objective to evaluate the efficacy of nirsevimab in preventing hospitalization due to RSV-associated lower respiratory tract infection up to 180 days after randomization. And the secondary objectives are to evaluate the efficacy of nirsevimab in preventing very severe RSV-associated LRT, and to evaluate the incidence of hospitalization due to RSV-associated LRT in each participating country, and evaluate the incidence of hospitalization due to all-cause lower respiratory tract infection, and to evaluate the safety outcome also. So study design, it's a phase 3B trial, pragmatic and event-driven trial, open label, multi-center, parallel 2-arm with randomized control trial with 1:1 randomization. And the study was conducted across 235 sites in primary and secondary care settings. That is 64 sites in Germany, 64 sites in France, and 107 sites in UK. So, what is an event outcome or event-driven trial? In traditional sample size calculation, target sample size calculated based on expected event rate. So, study duration is fixed, but outcomes rate may vary. If event rate falls lower than expected, the power becomes low. In event-driven study continue till pre-calculated number of outcome events occur, and study duration may drop or increase, and power is preserved. So more useful when outcome incidence is very low or unpredictable. So in our study, we planned enrollment of around 28,860 infants based on conservative RSV hospitalization incidence 1.1%. We assume that. But what actually happened, 2022-2023 RSV season had higher than expected attack rate. Post-COVID relaxation may increase the RSV circulation. So required primary endpoint events reached earlier. Enrollment paused at 8,058 randomized infant. So the Harmony study achieves sufficient events earlier. This is the PICO for the Harmony trial group. Population is studied at about infants less than or equal to 12 months and gestational age more than or equal to 29 weeks who are entering in their first RSV season with a sample size around 8,057. Intervention we are giving single intramuscular dose of nirsevimab based on weight 50 milligram less than 5 kg, 100 milligram more than or equal to 5 kg. And comparison we are comparing nirsevimab to standard care group, that is no RSV prophylaxis with the open label design. Outcome, the primary outcome is really RSV hospitalization assessed up to 180 days. Secondary, severe RSV and safety up to 365 days. And each of the component detailedly explained in the subsequent slides. The study population inclusion criteria: age less than or equal to 12 months, gestational age more than or equal to 29 weeks. They are entering the first RSV season, and the infants are otherwise healthy, not eligible for palivizumab, and parental guardian consent should be obtained. And RSV season, in much of the northern hemisphere, including UK, France, and Germany, RSV infection is clearly identified as a winter illness, and the most cases are observed over a period of approximately 5 months that usually start in October or November, which is commonly referred to as the RSV season in this region. So we can from October to March or from November to April, most of the cases occur. This depends on the RSV season. Exclusion criteria: known or suspected congenital or acute immunodeficiency, recent immunosuppressive therapy in the form of chemo, radiotherapy, prolonged systemic steroids, active confirmed RSV infection at randomization, active lower respiratory tract infection at randomization, moderate or severe acute illness or fever at dosing, non-hypersensitivity to study intervention or its component, laboratory confirmed or non-thrombocytopenia, bleeding disorder or recent anticoagulant use, maternal RSV vaccination during pregnancy, prior receipt of monoclonal antibody, receipt of immunoglobulin or blood products within past 3 months, participation in another intervention clinical study, or any condition interfering with study conduct or inability to comply with study procedure. These are the exclusion criteria applied in Harmony. Stratification, pre-randomization, the study population was stratified based on country and age group. Country: France, UK, Germany. Age group: less than or equal to 3 months, 3 to less than or equal to 6 months, and more than 6 months. So why stratified by country in Harmony? Because different RSV season timing across countries, different healthcare admission threshold, variation in testing practices for RSV, and different background of hospitalization rate. So ensure treatment arms balance with each healthcare system. This stratified by country should be procured. And why stratified by age? Because RSV severity is strongly age dependent. Highest hospitalization risk in less than or equal to 3 months. And if more younger infants allocated to one arm, biased result. So stratification ensured equal distribution of high-risk infants. Randomization, the centralized randomization by an interactive response technology system with 1:1 allocation to either group. So nirsevimab group around 4,038 infants and standard care group 4,019 infants. Allocation concealment, although Harmony was an open label trial, allocation concealment was ensured through a centralized web-based interface which minimizing the selection bias. So intervention, we can see that nirsevimab group received a single intramuscular dose with based on weight 50 milligram less than 5 kg, 100 milligram more than or equal to 5 kg. Standard care group, no RSV prophylaxis, no placebo injection, and data we collected from electronic diaries and reports submitted by parents and guardian. So safety monitoring from day 1 to day 365 we are taking. Events monitored are hospital admission, lower respiratory tract infection, any safety events. So in the right side of the diagram, we can see the 8,057 randomized, and out of these 4,013 assigned to nirsevimab, 4,019 assigned to standard care, and the further follow-up studies pattern of the study, we can see the diagram. The study outcome, the primary outcome is RSV associated LRTA hospitalization. So definition is a physician diagnosed LRTA plus RSV confirmed by diagnostic testing based on RT-PCR test, followed up to 180 days. In secondary, very severe RSV associated LRTA, that is RSV LRTA hospitalization plus saturation less than 90 or oxygen supplementation requirement, which is also followed up to 180 days. And other secondary outcome are country specific RSV hospitalization, that is incidence analyzed separately in France, Germany, UK, and all cause LRTA hospitalization, that is hospitalization due to any respiratory tract infection. Both of them followed up to 180 days. In safety outcomes, adverse events, non-serious adverse events followed up to day 31. Serious and medically attended adverse events, adverse event of special interest such as hypersensitivity, anaphylaxis, thrombocytopenia, and serious adverse events are followed up to 365 days. Statistical analysis, this is an intention to treat analysis, that is all participants are analyzed in the group to which they were originally randomized with a 95% confidence interval. And incidence rate calculated by the formula, incidence rate is equal to participant with event divided by total person time in months. And efficacy calculated with the formula 1 minus incidence rate ratio into 100. And the time to event analysis by Kaplan-Meier plot and subgroup analysis by the Forest plot, and statistical software used SAS version 9.4. And the study is funded by AstraZeneca and Sanofi. The results, the baseline demography we can see in the Thiruvananthapuram no intervention group, age at randomization is almost similar, 4 months, and age group, most of the case belong to less than or equal to 3 months, that is about 48.6% in Thiruvananthapuram no intervention also around 48. And just regarding the gestation age, most of the babies are term babies, which has similar distribution in both the Nirsevimab and no intervention, that is about 85.1%. And weight at baseline also having equal distribution. And country, most of the babies are coming from the UK, that's contributed to 50.8 in the Nirsevimab and similar to that of no intervention. And we can born in whether babies born in RSV season, born out of RSV season, also equally distributed. The results primary outcome, that is the RSV associated LRTA hospitalization up to 180 days. In Nirsevimab group, around 12 babies, that is from 4,038, 12 babies are reported, which is contributed to 0.3% with incidence rate of 0.001 per month. In standard care group, about 68 out of 4,090, which is corresponding to 1.7%. Incidence rate about 0.003 per month. So efficacy around 82.7% with the 95% confidence interval between 67.8 to 91.5. That is about 83% risk reduction in Nirsevimab post risk reduction about 83% compared to the standard group, standard care group with p-value less than 0.001. And from this we can detect absolute risk reduction about 1.4%. That is, RSV hospitalization prevented, 100 infants are treated, 1.4% prevented from the RSV hospitalization, and large likely reduction in RSV hospitalization, helpful at population level prevention. This is a Kaplan-Meier plot in which time to event analysis occurs. We will display x-axis represent the time and the y-axis represent the probability of remaining event free. Here the event is RSV hospitalization. So probability of remaining event free means no RSV hospitalization. So from 0 day it starts from 100%. So dip in y-axis means more and more RSV hospitalization. So in this, as you in previous study, previous slide we see incidence rate around 0.3 in Nirsevimab and 1.7 in control group. So that result difference is magnified in this Kaplan-Meier plot. And we can see an early separation, which will correspond to a early protection by Nirsevimab, and dip is more, and there is the curves are separated throughout the RSV season, which means efficacy is prolonged. That is, efficacy is throughout the RSV season 180 days period, and the separation is consistent. So which contributed the 83% efficacy, and the two curves are. This is the red dot represent the Nirsevimab no intervention, and the blue dot represent the Nirsevimab group. The two curves are analyzed with the log rank test, and we get the p-value about 0.001 less than, which is significant. In subgroup analysis by forest plot method, we can see the y-axis is the 0, no efficacy. Towards the right, nirsevimab better. Towards the left, no intervention. So all subgroup favors the nirsevimab group because when we look at the subgroup age less than maximum efficacy age less than or equal to 3 months, around 90.3% with confidence interval 75 to 96. And as the age increasing, the efficacy is slightly reduced to moderate efficacy and confidence interval widened, including the 0, which may lead to the lesser event as the age, lesser event of RSV incidence as the age progressing. And weight both less than 5 kg, more than 5 kg, both subgroup having good efficacy, and the timing of dosing also both before season are contributing to a positive finding that nirsevimab better. In result secondary outcome, very severe RC hospitalization in nirsevimab group about 6 out of 4,038, which is corresponding to 0.1%. Incidence rate less than 0.001% per month. And standard group around 24 cases reported, which is corresponding to 0.6%. Incidence rate is 0.001% per month. So efficacy of nirsevimab in very severe RSV hospitalization prevention is about 75.3% with confidence interval 38.1 to 91.8. Country level analysis, France have efficacy against RSV associated LRT hospitalization with the 95% confidence interval. In France, about 86.1, UK 85.9, Germany 74.4. So other secondary outcomes such as all cause LRT hospitalization, nirsevimab in group, there is incidence of 0.004% per month, that is 2%, having 82 LRT in out of 4,038, and standard age group it's about 3.4% with incidence rate 0.006% per month, and efficacy of nirsevimab about 41.9% overall. And in country wise, in France, about 32.2, UK 39.8%, Germany 64.1%. And safety outcome, regarding the safety outcome, nirsevimab was well tolerated. No apparent safety concerns were generated during the 12 months following randomization. Medically attended adverse event about 77% in both groups, mostly are mild, that is grade 1 to 2. And safety while assessing the safety outcome, grade 1 and grade 2 are similar incidents of in both nirsevimab and standard care group. So there is no significant safety concern in follow-up.
Sorry to intervene, Dr. Nikhil.
Yes, sir.
Dr. Nikhil.
Sir.
Sir, sorry to intervene. Can we a bit faster because the time is running out also. We can just tell the relevant points and try. I'm just mentioning only. Please continue.
Okay,
No, sir, it's almost over. I think we can go to the analysis. No need.
Okay.
No, sir. Let him complete, sir. Let Dr. complete, sir. It is okay. Please continue.
Strength of the study, it's a large multi-centric study, central randomization and stratification improves the comparability. It's a pragmatic design, enhance the real-world applicability, and consistency efficacy across the countries, and comprehensive safety monitoring. Limitations in open-label design, so it stands for bias and post-performance bias and detection bias, conducted in European setting, and no data for second RSV season, and reduced case numbers in late follow-up period. Direct comparison with Moderna RSV vaccine is not practical. Now, journals by Dr.
Thank you so much, sir. Over to Dr.
Good evening, all. Next is the journal analysis. We choose task checklist, critical appraisal skill program checklist for the appraisal of this journal. Here, this is a comprehensive checklist. We are analyzing the study characteristics, results, and the application for the local population. In the section A, the results are valid. Did the study address a clearly focused issue? Yes, the study addressed a clearly focused issue. They clearly defined PICO. The population and the PICO already Dr. Nikhil has explained. and a clear objective, prevention of RSV hospitalization. The objective is very clinically relevant because the prevention of RSV hospitalization will help in reduce the reduce the burden of RSV hospitalization and post-hospitalization sequelae, and healthcare services burden during the peak season. So the objective is clear, and the study clearly addresses a focus issue. Was the cohort recruited in an acceptable way? It's a multi-center study with clear exclusion and inclusion criteria and the large sample size. So the cohort recruited in an acceptable way. Was the intervention accurately measured to minimize the bias? The intervention was clearly defined. The single iron dose of nirsevimab based on the weight, and the random allocation was done by a central electronic web interface. But the study was an open label with no blinding, so there is a chance for potential biases there. Was the outcome accurately measured to minimize the bias? Mostly yes. The primary outcome they have assessed by RSV confirmation with the clinical definition and lab confirmed RSV. So, and they also provided clear definitions of RSV LRTA and very severe RSV LRTA. The similar outcome assessment in both groups, irrespective of the group they are allocated. But the problem, the limitation is there was no blinding, so there is a possible detection bias and observer bias will be there. But the lab confirmation with the RT-PCR reduces the risk to some extent. So the possible biases can happen in the studies. In the outcome analysis can be subjective, and because the clinicians making the decision know the study groups. So there will be a chance of performance and observer bias. Next is the parents are aware of the study groups and care seeking behavior might be influenced because of the treatment the children are getting. So there will be a chance of detection bias. And throughout the study, the sponsor is involved. The industry sponsorship is there. So there's a reporting bias is also there. And here there is no blinding was there because it's an open label study. So that is also a possibility for bringing bias. The authors address all the confounding factors. Almost the confounding factors are addressed, but the trial excluded higher risk infants. So the study cannot apply in higher risk infants. Have they taken account of the confounding factors in the design or analysis? Yes, they have randomized to similar group, parallel arm group, large sample size, and both groups are comparable in the baseline demographics and the characteristics. Was the follow-up of subjects was complete enough? The follow-up was complete. Follow-up up to day 186 months and person to time data are reported. Loss to follow-up also appears very minimal. Was the follow-up of subject was long enough? The follow-up was long enough. And next about the results, the study result it's already described. In nirsevimab group, the RSV hospitalization incidence is 0.3% compared to the no intervention standard care group, which is 1.7%. An efficacy of 82.7% with a 95% confidence interval with a narrow range of confidence interval with a significant p-value. So the results are significant. Secondary outcomes also. All-cause LRTA is in nirsevimab group is 2% versus 3.4% in the standard care group. Very severe RSV LRTA 0.1% versus 0.6% in standard group. In all the outcomes, the nirsevimab group has a better efficacy compared to the standard care group. How precise are the results? The results are precise with a narrow confidence intervals, and the incidence rates are reported in absolute numbers with a significant p-value. So it's the results may be it's very unlikely due to chance, and the results are statistically significant. Do you believe the results? We can believe the results, but with minimum caution because it's an open label study with a sponsor involvement in design, analysis, and throughout the process. And it's only studied in healthy infants. But the positive points are the large RCT with multi-center involvement. And the objective is also biologically explainable because the nirsevimab is a monoclonal antibody against RSV protein. So its efficacy can explain biologically also. Will the results help locally? Can the results be applied to the local population? Partially, yes, it's applicable to healthy term and late preterm infants and in the first RSV season. As per the study, it's applicable. But the limitations in low medium income countries are not sure because generalizability is less because they are studied only in high income countries like France, UK, and Germany. Higher seasons are not studied, and seasonal variations will be there, especially with our country. There are seasonal variations from we have seasons in June to September, and we also have in northeastern states we have seasons in December to February. So we have entirely different season than the countries they have studied. To the results of this study with other available evidences. Already they have studied the efficacy of the nirsevimab in other studies like MELODY trials, MEDGI trials, and the nirsevimab harmony earlier study also they have studied. So the available evidence, the study is applicable. What are the implications of this study for practice? The study provides sufficiently robust evidence to recommend changes to clinical practice or within health policy decision making, suggests an acceptable evidence for prevention of RSV, LRT associated hospitalization in healthy infants. It could significantly reduce the hospital burden, but the cost effectiveness and implementation needs evaluation, especially in the countries like in our country, in the setting of our country. So coming to the appraisal summary, positive or methodologically sound things are the large multi-centric RCT, which address a clearly focused question, objective outcome measures, and with a strong effect size, good safety profile, minimal loss to follow. The negative things are open label study with no blinding and sponsor involvement throughout the study. Ethnicity is also not described in the population, and they excluded very high risk infants. And future studies may be needed in case of long-term immunity beyond 180 days, cost effectiveness in low and medium income countries, and impact in higher groups may need more studies. And we also appraise the journal with the Consort 2025 checklist. This is somewhat similar only.
That is, we can skip through it.
Okay.
When consult most elements are met, we can leave it for discussion.
So in concluding, it's a valid study with clinically relevant objective and applicable to general infant population, support implementation of RSV prophylaxis in making health policies. But the limitations are open label study, so sponsor involvement and epidemiological constraints which limit the generalizability, and the cost effectiveness in low medium income countries is questionable. And the future research needed in possible protection by nirsevimab across the second RSV season, and follow-up from the Harmony trial has been extended beyond 12 months. And if we have to do more studies to state an impact on incidence of recurrent disease post RSV, and we need more studies to state the generalizability in low income and middle income countries for the RSV prophylaxis.
Okay, thank you so much. I should tell that the presentations were excellent. They're precise, crisp, and clear, and also for the excellent mentoring. Thank you and congratulations to Dr. Nikhil Raj TS and Dr. Vidya VS. And now we will go to the expert panel. I would like to request Dr. Ramkoti sir to express his observation, his opinions. Over to Dr. Ramkoti.
Okay, thank you. I hope I'm audible.
Yes, sir.
Yeah, this is a very interesting paper, and I think it has been well presented. As usual, the residents have done a good job. Both the presentation as well as analysis was good, and also the earlier presentation on phases of clinical trials. There is some slight difference in some people divide it differently, but that's not important. But this is the most accepted kind of classification of clinical trials. And in this respect, I would just like to comment on something which, it's not important, but it's maybe of interest to many people, that this phase 4 of post-market surveillance actually is very huge. And the corporates, that is the pharma companies, spend a lot of money on this, and there are very good job opportunities for people. In fact, at least I know two students of mine who are now in Bombay employed by pharma companies, getting fat salary and traveling all over the world, just doing post-marketing surveillance. So that's a very good area for jobs. Anyway, that's not important. But actually, coming to the presentation, there's nothing much to say there except that one or two comments I want to make is. First of all, when you report incidence rate, it is not 0.003 person months. It should be 0.003 per person month or 0.3 per 100 person months. Because the numerator is the event, number of events, and the denominator is the person months. So that should be clear. And so I don't know if the paper has reported it like that. I didn't really check. But if it has done that, even that is wrong. So that is one comment. And the thing is that why I mean nobody commented on why there was no blinding or masking.
Yes.
It's obvious because I mean I know everybody knows that, but nobody talked about it. Obviously because you can't do a sham injection for an infant. I don't think any ethics committee would allow that. Even I'm an ethics committee, I would not allow that. So that is probably why they didn't have a blind arm. So that should have been mentioned. I think this is why they didn't. I mean, that is, of course, one of the weaknesses or limitations of the study. But I don't think it's a major limitation because looking at the number of events. And the other broad comment I want to make is that recently, we have been discussing clinical trials, which is good. I mean, for clinicians, I think that's most important. We want to know the most important kind of interventions that are very effective, efficacious, and all that. But from a research point of view, there are many other designs. So probably you have to at least occasionally bring a paper with some other kind of approach. I think that would be interesting. And of course, otherwise, this presentation was very, very good. And of course, they have used the CASP guidelines or the checklist, which is not very different from the consort. Both are equally effective, so that's not an issue. I think I should appreciate the students, who have gone to the trouble of, not the students, the residents, gone to the trouble of doing this meticulously. And I don't know anything about the cost, so I don't know whether it's applicable locally at all. So that is another big question. So from the health technology assessment point of view, that is what is the cost benefit trade-off. And I don't even know if we really diagnose RSV by virological means or anything. I don't know how it is done. And how sure can you be that it is RSV, etc. Those things I don't know. I'm not completely ignorant. So you can discuss that. So this is all I have to say. If you have any questions, I will be glad to answer.
Divakar, shall I take Sir's last 2 points just to clarify?
Yeah.
Okay, ma'am. Okay.
Sir, we've started using this for the last 4 or 5 months now. And for babies who are less than 32 weeks, we offer it to the parents, give them an honest disclosure of the costs as well as the lack of data in India. But we let them do their own Google search with correct websites as to how effective it is in other countries. Sir, Nirsevimab is available as a pre-filled syringe, which is 0.5 ml if it is 50 milligram and 1 ml if it is 100 milligram. And the doses for every less than 5 kilo baby, it's 0.5 ml, which is 50 milligram. So now we're buying the 100 mg per ml vial syringe, sir, and dividing it in 2 babies who are eligible to receive it on the same day. So we take out 0.5 from the pre-filled, give it to one baby, take out another 0.5 from the same syringe and give it to another baby. So their parents are also aware that we're sharing the costs. So each 100 mg per ml vial is 39,000 to the patient. And so it gets divided to around 20K. It's a single shot forever. That is for 5 months only we are giving it. So we're not yet giving a second dose or anything. So they're happy to take it. Nobody has refused it. Efficacy we are yet to see in our settings, sir. But RSV, yes, we do PCR and we prove if the baby requires hospitalization. Otherwise, we don't do in the OP visits. So that will be underestimated anyway, I believe, in our settings, sir. And interestingly, the cost is the same for the 50 mg vial and for the 100 mg vial. So we started buying only the 100 mg vial and we're dividing it, sir.
And one more thing about passive immunization is that I recently read that now in adults also they have introduced for flu. They used to have the flu vaccine every year. Now they're trying a nasal drop, antibody nasal drops, which covers a huge spectrum of viruses, so that you don't have to have specific antidotes against each virus. So they are trying it out. I don't think it's really popular yet, but I think clinical trials are showing. I mean, this is for elderly people, not for infants. But this passive immunization is coming in a big way.
Divakar, Dr.
Yeah.
Anju?
Yeah. Thank you, Femita ma'am and Ramanguti sir. Sir, just regarding the methodology, blinding, can we really say that it did not have much effect considering the studies outcomes? Even the outcome is quite subjective actually. It was physician diagnosed LRTI with the RSV positivity. RSV positivity is very objective. But the physician diagnosed LRTI in an unblinded setting. Should they have chosen a better, more objective outcome when they are doing an unblinded study? Like, and especially when the final outcome numbers are still less, it is less than 100 in both the groups. So it can be still variable, right? I mean, I'm just expressing my thought. So is it
Yeah,
sufficient data to tell, I mean, to generate a policy change?
maybe you're right. I mean, I don't know the ground reality, so you may be right. Only thing is the practical difficulty of blinding in such a
Yes.
situation is very.
Yes.
That is the problem, I think, here. That why they did not go in for. One thing in such situations you can do is the assessment can be done by blinded people. I don't know if that is possible here. Whether
They had just mentioned the assessors were not part of the original study group, but they were. I mean, most likely everybody. I mean, it would have been in their medical records whether they
yeah,
received it or not.
yeah.
Okay, can I come in for a minute?
Yes.
See, I have a different take on this study, and
Yes.
I want the students, everybody, to be very careful about
Yes.
sort of
Exactly, sir.
medications. Number one is this is bronchiolitis is well known to be severe in the West
Yes.
and not in the South in healthy children. Okay. Now, palbociclib is a drug which I used in the Gulf. The moment the neonatologist started ventilating children below 29 weeks, 28 weeks, made them all right, sent them home. We found out that even a small cold, the child has a nasal block, and within a day he's gone. That is the risk of RSV. Even in the Gulf, the winter is more severe. When I came back to India and I asked in 2017 to two neonatologists, what's the criteria for giving palmiximab? He asked, what is that drug? And he said, RSV is not so severe. And I warned every young pediatrician, if you see a child in the night who has been discharged from the SCABU, coming back even with a running nose, admitted, because it is only hours before it does. Now, coming to the healthy child, I was a little surprised this you are giving this to healthy child. They are advocating it for healthy children in tropical countries. And you know what is the best immunization you can give? Breastfeeding. Please understand this. Where is the confounding in breastfeeding in this? Because I'm sure 100% of those children in Germany and France have not been breastfed. So therefore, that's a very important background in this. Therefore, and for Dr. Ramaguti, the cost of one medicine, I understand, is 40,000 rupees. Maybe the KIMS is getting it at a lower cost. Therefore, if you are providing this medicine to a child who is admitted, at the same time, the child is not getting exclusive breastfeeding for 6 months, you have failed as a pediatrician. And the pharmacology and the pharmacist has simply used you for his medicine. That's what I would say. Because breastfeeding is the most important thing which will And bronchiolitis, the high risk is below 3 months, ex-preterm, of course, children who are having. And even when I was in the Gulf, there was a big fight between the British consultants and the American consultants. The British consultants openly said that these companies are pushing for more and more children to get this costly drug. At that time, one dose of paramiximab was $2,000, and 5 doses you can calculate. And they wanted to make it from 28 weeks to 32 weeks. 28 weeks to 32 weeks. And they objected to it very strongly, the people from UK. Now here we are advocating for normal children. Remember that. Normal children. I don't mind giving it. Definitely it is useful for babies below 29 weeks, ex-bronchopulmonary, patients who are on oxygen for which we call chronic lung disease up to 28 weeks, definitely it might be useful. But this for normal babies, unless they do real studies, cost-benefit ratio, tropical countries, look at the risk in Indian babies, especially in South India, in babies who are breastfed. I wouldn't advocate this medicine, whatever be the evidence. Thank you.
Thank you, sir. An excellent point.
One comment I would like to make about the confounding of breastfeeding, because when you have enough numbers and you are randomizing, it should take care of that, right?
But what is the rate of breastfeeding in the Western countries?
Yeah, but it will be equal in both.
They say 180 days, and there the majority of the population, or 90% of the population, will not be feeding above 4 weeks or 8 weeks.
But that's from the design point of view, because it will be equally distributed in both wings, both arms.
But it's not going to be applicable to Indian conditions, isn't it?
No, here also, if you are randomized, it should be equal in both. I mean, you can check, of course, but I don't know whether they have checked. Yeah. That is part of the reason why we randomize. Otherwise, there is no.
What is happening now is in corporate, BFHI is given a brand for even corporate hospitals. One bottle, one tin kept in the neonatal unit without the baby and the register entered means BFHI is gone. As per BFHI, I have gone as inspector. But in spite of it, many of the Kerala hospitals, where I have seen, there are multiple, the babies are given powder, which means that these babies are not exclusively breastfed. Though we talk of it, we don't introduce it. Therefore, we are not giving the best antibody to the child, which is available free. And we are now advocating something which is a very, very costly thing. And that too to normal, healthy babies.
Sir,
that is something which I think is not acceptable unless you do those studies in India, and we should tell the pharma company, come and do it in India on babies who are breastfed. Then we will accept it.
Okay, sir. Thank you, sir. The presentation was not about advocating Nasimab. It's just to create the discussion. We highlighted.
There are a lot of young pediatricians.
Yes, yeah, that is obvious.
Yes, that's
exactly.
Sir. Thanks for highlighting. Even that was my second question to Ramankuti sir also. They had made an initial publication in 2023 with this data. 2022 the observation was made, and 2023 till the primary objective was based on till the RSV season ends. And now they have published in 2026 with the follow-up till 180 days. Obviously, maybe follow-up till 1 year, the hypothesis may not hold. The antibodies duration may offer protection till 6 months. Maybe we can't expect a protection for 1 year. But that 6 months data could have come quite some time back. But the publication has come now. But so far, whether that has any relationship with trying to make changes in policy also is a question in background. So,
I think policy change will not be based on just one study. That is probably not.
No, but I think I think Femita ma'am can tell. I think UK the policy has changed. They started a recommendation, right?
The CDC has, the WHO also has. So we as National Neonatology Forum has revised in 2025 for high risk infants only, not for low risk infants at all. Considering exactly what Padmanabhan sir said, that most of the disease is not severe, and whoever gets affected severely is the high risk, extreme preterm or very preterm. So currently NNF also says only
Excuse
for
me. Excuse me, madam. One doubt I had is Divakar sir has told, and Padmanabhan sir has also brought up it actually. We were telling about maternal vaccination against RSV. What about that, madam? Is it available in India, and is that less cost effective? Cost wise it is less. Can we, invest on that actually? One query.
Yeah, right now maternal vaccine for RSV is not available in India, and the NNF position statement will also probably get revised when it comes, whenever that is, because you can see that palivizumab itself came only in 2024 end, and they withdrew it as soon as nirsevimab came into the market. That is only for high risk babies as of now. Maternal vaccine is not yet here. There are some issues with maternal vaccine currently with the data that it should be given between 24 weeks to 36 weeks, and it should be given at least 2 weeks before delivery. Now, for a preterm baby, it's very difficult to predict when that's going to happen and whether you will get that 2 week window, whether that's enough for the baby or not. And there is a small data from African countries which says that the vaccine itself may cause some premature birth. So right now we don't have the maternal vaccine yet.
Okay. Thanks. Okay, thanks for the clarification, madam. And
Yeah,
the
one
topic is
thing I
open for
wonder
discussion.
is why
And
did
after,
these people don't do,
yes, sir.
see when they do a dengue vaccine, they go to Africa. When they go to these, why didn't they do the study in India? Why didn't they do it in India? Because that's where the market is. They go to France and Germany and UK, where the incidence of bronchiolitis is very high. If you have been in UK, you will know during winter, 90% of the pediatric ward will be bronchiolitis, and severe ones. And they show the efficacy there. Why don't they do it in India and show it? And now what's going to happen is the corporate hospitals of India are going to swallow this data and start giving it without if they make the same effort in giving breastfeeding, promoting so severely, more than this monoclonal antibody, I'll be very happy. But unfortunately, many patients go out of the delivery of the corporate hospitals and even our medium level hospitals without having adequate counseling for exclusive breastfeeding for 6 months. That's not happening now. And now we will have promotions and clinics for monoclonal antibodies in these hospitals.
Thank you, sir. The topic is open for discussion, and after the discussion, it may be wind up by Dr. Srijit sir, and I think Premila madam and other seniors are also there in the meeting, and they can also contribute.
He's talking.
Srijit sir?
I think everyone went to the next meeting. We can.
There's another meeting, is it?
I think some other program was there for IAP Thiruvananthapuram. I think we can stop. Okay. Anju sir, shall we end it?
Anju sir told me he's on duty, so if he's not there, maybe Srijit sir, Ramamurthy sir, Padmanabhan sir, any concluding remarks?
Yeah, I think I talked enough. Let's end.
Thank you. I would like to express my sincere thank you, Padmanabhan sir, Ramamurthy sir, Dr. Femida, Dr. Divakar Jose sir.
See, why I talk so much is I have used palmiximab. I have used, I don't know, I have not given it to healthy children. It's very, very effective in small newborns. We felt safe after that. But with healthy newborn babies in tropical countries, I'm really shocked.
Okay. Femida madam, nowadays from KIMS, which type of candidates? I mean, how do you determine the candidates for the nirsevimab? Do you give to every baby?
No,
I mean,
no.
if it is already discussed topology. Okay.
No, not for all babies, not at all. Even the NNF is not recommending it for all babies. It's for very preterm just now. We are offering it to less than 32, but most of the population who are taking it is the ones which are less than 28 weeks, like Sir told, no?
There are American guidelines, 29 weeks, chronic lung disease. There's definite guidelines. But you know, you had to give palmiximab for 5 months, every month, is it not? And what's the cost it comes to? You might
The
be.
palivizumab would have gone up to 1 lakh. That is not being used now. Nirsevimab is only 1 dose, so it's coming to 20K if it's divided into 2 babies, sir.
So you are giving it for preterms also.
Preterms only, sir. Preterms, we done 1
So
or
this
2
study
babies.
is for healthy babies. That's why I asked.
Yes, sir. The trial is for more than 29. That is not at all a group which we are not at all for healthy infants, not yet at least.
Okay, definitely it is indicated for babies 29 weeks. I don't know about 32 weeks. I'm not too sure. Because in the Gulf, if you give it for 32 weeks, the insurance will not approve it. So therefore, we were giving it only after 29 weeks. And it was very, very effective. Let me tell you that. Right? And there's a definite difference in the severity of mortality and morbidity in children who are given these monoclonal antibodies. And also breastfed babies. Breastfed babies also do much better if they are exclusively breastfed. Thank you. Shall we close it then?
Yes.
Anju?
Yes, sir. We can close it, sir. Dr. Srijit is there? Dr. Srijit, sir?
He's not.
Okay, if Srijit sir is not there, I will like to express my sincere thanks to all the people. As I have said, Rabbi Sir Patnavan sir, Femida madam, Divagar Jo sir, Neetu madam, and our two good, excellent presentation by the two postgraduates. And till we meet next time, we'll call it a day. And thanks for the wonderful session. Thank you, sir. Good day.